Ladies and gentlemen, we now move on to track 4. This is a special session where the esteemed ANEI Patient Safety Fellows will present their projects they have undertaken during their fellowship program. To take this forward and welcome the most important dignitary of this track, may I now invite Ms. Tankam Bomis Ma'am, Founder President ANEI, to come forward and extend a warm welcome to our respected Dr. Michael Ramsey sir. Hello sir, are you able to see me?
Yes, I am.
Okay, thank you so much. Ladies and gentlemen, it's such an honor to be presenting Dr. Michael Ramsey to all of you. How many intensive care nurses are here? Please raise your hands. How many of you use Ramsey sedation scale? Wow. So you are honored to see the founder of Ramsey sedation scale. Can you imagine? Please give up to Dr. Michael Ramsey. Today he is here in the capacity of Chief Executive Officer, Patient Safety Movement Foundation, USA. And we are so honored to have sir here with us. We can see you very clearly. Thank you so much. It's very difficult to summarize who he is and what he is for ANEI. We started this ANEI fellowship program, 4 years ago with the blessing of Dr. Michael Ramsey and the foundation from USA. Their vision is to prevent all avoidable harm. And ANEI stands for patient safety. With that, we started this fellowship in collaboration with Patient Safety Movement Foundation, and every year we get the fellows and we also get them to do projects. And sir, today we have the cohort. Can I continue to speak? Okay. Today we have the cohort 4 presenting their projects, and we are sitting in northeast state of India, that is Guwahati. And many of them could not make it. It's pretty far for everyone to reach. It takes a lot of time to reach here. So we have 2 of the fellows presenting today. The rest are on the video recording. And I really hope you can hear us very well, sir. Can you hear me?
Yes, I can.
Okay. Thank you so much. I'm just confirming. And we would definitely like, after we listen to your precious address, the gathering is waiting for your words, sir. Thank you so much. And please, ladies and gentlemen, it is 2 a.m. in Dallas, in USA. And sir is up just for us. So when I look at him, I tell myself, I cannot retire. No excuse for me. Thank you so much, sir. Over to you. We are waiting to listen to you. Thank you.
Ms. Thankum Gomez, thank you so much, and thank you for the Association of Nurse Executives of India for really focusing on patient safety. And this week is the World Health Organization's World Patient Safety Day, and so it's really a very appropriate time to have your conference. And the focus for this next year from the World Health Organization is going to be towards zero harm and safety of the child. But from the start, we're going to look at safety and from the youngest as they get older. So this is really a great week to have the Association of Nurse Executives of India's meeting. And I'm really looking forward to hear the presentations from your fellows. I love the idea that you have put together a handbook of patient safety for nurses, which I think is going to be a really great addition as we really fight to improve patient safety. It's a struggle. People don't mean to hurt patients in healthcare, but still it happens. In the United States, where I'm running the Patient Safety Movement Foundation, it is a global organization too, but we have at least 1 in 4 patients who enter our health. Way too many. We now know the causes. We've got to educate everybody like you are doing today to be sure that we can prevent the harm, because all the harm is preventable. And that's the goal that we have, it's a goal that you have, and together, particularly with the nursing population, we can make a difference. So I think this is a very important meeting. I'm just so very glad to be invited here with your other important guests that you have, Dr. Professor Ashok Puranik, Dr. Siddharth Singh, and myself. This is really a great honor. So thank you all indeed for being here. And I'm just really looking, and I'll thank your president, Dr. Ajit Nair, as well, so much for this invitation. And I'm going to keep this short because I really want to hear what your fellows have come up with and their presentations, because it really does look like an exciting program. So with that, I'm going to stop, because I really want to listen to about this handbook for patient safety for nursing students and faculty. I think this is going to be a great addition to patient safety, not just in India, but across the globe. So with that, I'm going to thank everybody for this kind invitation, and I look forward to hearing these presentations.
Thank you so much, sir. We would like to hear your comments after all the ANEI Patient Safety Fellows presentations have been done. This is definitely the high point for our fellowship program. Thank you for your continued patronage, and now we move over to the presentations. I will hand it back to our anchor, Rebecca.
Thank you once again, sir. Now we move forward to the project presentation by our esteemed ANEI Patient Safety Fellows Cohort 3. To begin, I would like to invite respected Dr. Davindra Kaur ma'am, ANEI Patient Safety Fellow Cohort 4, to present their project on Handbook on Patient Safety for Nursing Students and Faculties.
Good afternoon, everyone, and Dr. Michael Ramsey. So I am Dr. Davindra Kaur, Cohort 4 Fellow of ANEI Safety Fellowship Program in collaboration with Patient Safety Foundation Movement USA. So I am presenting this book, Handbook on Patient Safety. So last year when people were selected for the fellowship program, ANEI fellowship program, so that time we had 2-3 admissions were there. That time this idea came to the mind that we should write one handbook on patient safety for the Indian nurses and the student nurses. So we have taken this project as a patient safety fellowship program. So I am presenting this book on handbook on patient safety. So although nurses are the backbone of patient care, but unfortunately they lack a structured training program. In hospital scenario, there are so many preventable errors that occur in clinical area. But we have to prevent them to promote zero harm. So that time there was an urgent need that we should have some book, Indian rooted book, so that it will have the clinical realities from Indian scenario that will work as a source guide for the practicing nursing and for the students to prevent zero harm in the patient. So this book is aligned with the international standard because in incorporating or the international patient safety goals, along with, but it's rooted in the Indian realities, along with the clinical practice realities that has been there, so that it will work as a really good resource book for the nurses. They can read that book, they can follow that book to prevent zero harm in the hospital area and provide the safer and quality patient care to the patient. So this book is a teamwork, collaborative teamwork with my colleagues from the Cohort 4 and Cohort 3 under the strong mentorship of Ma'am Hungam Games, because Ma'am has given the format of the chapters that we have to incorporate it in the book. So this book has 11 chapters. The first few chapters we have incorporated all the international patient safety goals, and otherwise we have the chapters on the safety culture, communication, prevention of infection and the other topics. But what is the more powerful material that we have included, that will give the clinical realities to the nurses, that we have the clinical based case scenarios, and along with the case scenarios we have the multiple choice questions along with the rationals. So in this way they will have a complete, we can say, as a source guide that can be available very soon in the market. So we are very happy to announce that JP Publishers, they have accepted this manuscript. So very soon it will be available in the market. That will work as a source guide for the student nurses and for the practicing nurses. So here is the cover page of the book that will be available. So all the chapters, they have the same format, and the case scenarios, then content matter, then even the simulation points, then multiple choice questions along with the rationals. So I will thank all the ANEI members, ANEI and the Patient Safety Foundation USA. Along with that, I will extend my sincere thanks and regards to Dr. Michael Ramsey, ma'am, and my fellow colleagues, and the other ANEI members and everyone for making this book that will be available for the nurses. That will be the one step towards the goal of zero harm in the clinical area, because we are committed to safe, effective and compassionate care to the patients. Thank you so much.
Thank you so much, ma'am. Next, I would like to call upon respected Ms. Swarnalata Batra, ma'am, ANEI Patient Safety Fellow Cohort 4, to present a project on reducing peripheral IV catheter failure.
Hello everyone and very good afternoon, one and all present over here. And this is my privilege to stand in front of you all in this ANEI Patient Safety Conference at East Zone, Northeast Zone of Guwahati. And I would like to thank ANEI and the most passionate mentor of Patient Safety Fellow, Madam Thankam Gomez, to give this opportunity to talk in front of you all today. And I would like to, thanks to my mentor, Ms. Jyoti, of Cohort 3, and my CNO and all the members of my organization who has given support and contribution towards this QIP project. And before going to start my QIP project, I would like to thank and my sincere gratitude to the CEO of Patient Safety Movement Foundation of USA, Dr. Michael Ramsey. Sir, it's my great privilege that I am talking in front of you. And to be honest, I am a proud Patient Safety Fellow of Cohort 4. So thank you so much. So coming to the presentation of my QIP project, my problem statement is high PABC failure rates that cause patient discomfort, complications, risk of infections and increased workload due to inconsistent practices and lack of standardized care. So on the basis of this problem statement, we have set our objectives and goal in the form of SMART, and the main specific objective is to reduce the peripheral IV catheter failure rate around 47%, to decrease the failure rate of IV cannulation from 47% to 20%, to standardize the protocol and decrease the risk of IV complications, and to make it happen, we have kept a time bound of 6 to 8 months. So these are some glimpses of PIVC failure. And coming to the most important part of our QIP, before going to start our post-QIP, we have done a pre-QIP study with a sample size of 204 from the ward and ICU, and we have seen there are many scope of assessment during our pre-QIP, and the most important part is that the average enrolling time of IV catheter, we have seen around 2.7 days, and out of this 53% of cases are the reasonable removal of IV catheters, and the IV catheters are removed due to the complications around 47%. Though we have seen that around 85% of cases, the fast attempt cannulation is success, but however the close port compliance was only 54%. So coming to the background and the baseline data as for our pre-QIP study, we have seen that in 36% of cases, the metacarpal vein are the fast choice of cannulation, and in 75% of cases, 20-gauge cannula has been used. However, there is a challenge that we got. The vein selected and the size of the cannula that we had chosen was not appropriate as per the guidelines. So as per the flushing protocol adherence towards the flushing adherence protocol, we have seen that around 50% of cases there is an occlusion because the nurses has preferred more manual flush than the pre-filled syringes, and in 61% of cases only one moment of flushing they have added, that is the before medication, though the guideline also recommended that the flushing protocol should be in between the medications, after medications, and when not in use. And also we have seen that the compliance rate towards the types of connector used in there is a variations in the technology they have used, and the complication rate without open port is around 45%. And throughout this QIP we have seen the two major complications related to IV was the phlebitis, as the mechanical phlebitis, as well as the occlusion. So on that basis of this need of the study, we have done an RCA of our QIP project, and we have seen there are so many factors are contributing this increased rate of PIVC failure. These are mainly the lack of training, variations in the technique, poor adherence to the best practices, lack of regular audits, high patient acuity, especially the obesity and the fragile veins, and inadequate data collections, and also we have seen there is an inadequate monitoring towards the PIVC. As well, there is an inappropriate gauge size used as per the patient vein, mainly is contributing for this increased rate of PIVC failure. So on the basis of this RCA, we have set our PDSA cycle as a methodology to way forward for our QIP. So this is plan, do, study and act methodology we have taken, and we have followed the standardized guidelines of INICC, INS and CDC. And we have intervened the best practices. These are some glimpses of our audit and training on PIVC. And on the basis of the recommendations, we also implemented the PIVC bundle KA followed with the PIVC complication tracker. And we encourage our nurses to use pre-filled syringes rather than the manual flush. And also we have implemented the closed slit septums rather than the open port system. So this is how we have done the intervention as per the methodology. And as a result, you can see there is a variations from the before and after 3 months of our PIVC implementation of our QIP. There is a huge reduction in our phlebitis and the occlusion, the most important of the IV complications. And the best practices to adhere the split septum device as well as the flushing adherence has been seen. It is increased more than is 88%. And however, these best practices are causing more impact on our enduring time of the IV, the termination that is increased from 2.9 days to 3.4 days. So if I will come to the conclusion part, by adhering these all protocols and the best practices, we have seen there is a reduction in PIVC failure from 47% to 20%. There is a lower complications rate of phlebitis and occlusion, and mostly the enduring time of the IV catheters has been improved from 2.9 days to 3.4 days. And the most importantly, it is helping to reduction in the reinsertion, which is leading to the patient comfort and satisfaction. So a way forward throughout our QIP project, we are committed to standardize the practices across the hospital. We are giving the focus on the implementation of the bundle care of insertion and maintenance. We are encouraging our nurses to continue this implementation of the technology, and also we created an IV team to implement this infusion upgraded practices and the surveillance for the better outcome. So coming to the summary of my QIP project, it is my privilege to tell you that by adhering all these guidelines, there is a huge reduction of this PIBC failure as well as the complications of PIBC, and it helping for the greater satisfaction among our patients because of there is a lesser of reinsertions and the fast attempt success was high, and also it is helping to improve the staff confidence because of the standardized protocols. And overall, if I say, the initiation, it helped to enhance our patient safety, improve the quality of care, and demonstrate the importance of consistency of best practices for sustainability. So thank you so much. And if any questions, I would like to take in the back side. Thank you.
Thank you so much, ma'am. We deeply appreciate your clear and thoughtful presentation. Moving ahead, I now invite respected Ms. Anuradha Batra ma'am, ANEI Patient Safety Fellow, Cohort 4, who will be presenting their project on reducing falls in admitted patients through a video presentation.
Safety Fellowship Cohort 4. I would like to extend my sincere gratitude to ANEI, Dr. Michael Ramsey, Manthangam Pomos, for giving this opportunity to present my QIP here. Let me share my slides. Please give me a minute. My QIP is to reduce the incidence of patient falls and enhance the patient safety. The team members, this is the QIP we started from AIG hospitals. My team members are here, and this team was really helped me to complete this QIP successfully. The falls in the hospital are the major safety concern, often leading to injuries and prolonged recovery and reduced quality of life. We have taken this QIP due to increased number of patient falls that leads to the cost of care increase, poor satisfaction and fractures, and increase in the length of stay. Aims of this QIP to reduce the number of patient falls in AIG hospital, to improve the staff knowledge on fall assessment and fall prevention measures, to create an awareness among the patient and family members on fall prevention. The incidence of falls, we have taken this data from the month of September to January month, and we have been observed there was a number of falls increase in the month of January. It was 8 patient falls. The root cause analysis, based on this, we have identified that these are the main reasons why the number of patient falls have been increased. Going to the washroom alone without using corbels, skipping the leg exercises after getting out of the bed, elderly patient with multiple comorbidities, material absence of anti-skid mats near the washroom, side desks were easily removable. The procedure-related peg leg preparation was initiated in the evening till the night, and NBM subsequent NBM pre-procedure. The system-related corbels response was very delayed, poor room orientation, inadequate washroom cleaning. The fall patient numbers were increased in the morning hours. The staff factors, incomplete fall risk assessment, no explanation of leg exercise before moving out of the bed, infrequent rounds for these patients. Based on the PDSA, we have planned prepare the audit tool to assess the patient vulnerability status, patient awareness on the fall prevention measures, assess the staff knowledge on fall scoring and fall prevention teaching. The target to reduce the patient falls 50% in the next 5 months. Do analyze the data and create the interventions to improve the non-compliance, prepare video-assisted teaching materials for the patients and family members on the prevention awareness, conduct a workshop and trainings for the staff nurses, introducing new products for the prevention. Study conducting regular fall risk assessment, documentation, monitor fall rates, conduct patient and staff feedbacks. Act to standardize the effective practice into the hospital policy, recognize the staff compliance, good practices. Pre-intervention audit findings, these are the parameters which we have taken, the sample size we have taken 150, and if you look at all the parameters are lower risk at the lower side, and the interventions are much required here. Compliance percent of staff knowledge as well, the same, if the for risk assessment performed was just 18% and the score documentation was less side, video display was only 20% and staff aware of all education brochures and other parameters also at the lower side. These are the interventions we applied here. These are the glimpse of our fall workshop, fall prevention workshop, and flash mob is created. These are the two things which really impacted the nurses, and they applied at the bedside. Fall prevention video created and displayed on the TV screens. At the time of admission, the concerned nurse will do this and followed by all the 3 shift nurses. For prevention brochures, and we have prepared a sling at the patient bedside. This will be available in both cards, and the nurses will be using these cards to explain to the patient and family for the education. Anti-skid bathroom are introduced, wheelchair beds were repaired. Post-intervention, here we are, and out of our fall prevention initiatives has shown a positive outcome. We observed a significant reduction in the patient fall numbers. If you look at from the Jan, we had 8 falls, but it has been decreased to 2 patient falls only over the period of 5 months. The staff knowledge also was very improved, and the nurses were really empowered and more confident, and this resulted better practices for the nurses and for the patients and family members. If you look at the percentage of the pre-audit was only 64.6%, but whereas if you look at post-audit, post-intervention 96.2%. The result on the audit, QIP audit, post-intervention demonstrated significant improvement in the compliance with fall prevention measures, and all the parameters have been improved successfully. In the conclusion, there has been a significant decrease in the incident of patient falls from 0.12 to 0.8, approximately 40% reduction, and also the staff knowledge improved 64.6 to 96.2%. Way forward, the audit will continue as a point of prevalence audit in every month. Imparting knowledge to the staff will continue in the form of induction and workshops, and monitoring the incidents of patient falls. And the RCA will be monitored, the nurses will be involved in the RCA, and patient interviews will be conducted during this RCA, and new interventions will be carried forwarded to mitigate the risk. These are my references of my QIP. Thank you so much once again for giving this opportunity. I would like to extend my sincere gratitude to ANEI, Mangtangam, my mentor Ms. Rafia, and to all the audience who are listening this my QIP. Thank you once again. Namaste.
Sir Thangaraj sir, ANEI Patient Safety Fellow Cohort 4, who will present their project on patient and family engagement in healthcare, a public opinion survey in the public sector via video presentation.
5th Annual Patient Safety Conference at AIIMS Guwahati. First and foremost, I'd like to thank Dr. Michael Ramsey, CEO, Patient Safety Movement Foundation USA, and Ms. Tanvam Gomez, Mentor for Patient Safety Fellowship, for giving this opportunity. And further, I'd like to extend my sincere thanks to my mentor, Mr. Abdul Dayab, for his constant support and guidance in completion of this study. So I have taken as patient and family engagement as a safety strategy. So as it is a core element of safe healthcare system as emphasized by WHO and Patient Safety Movement Foundation. So as a Patient Safety Day 2023 highlighted that engaging the patient for patient safety. And there are various studies which highlighted the patient safety engagement reduced the There is a critical baseline gap in the patient and family engagement in their own safety and care. And it also explored there is a need for analysis the patient and family engagement in the Indian context. So through this strong evidence, so I have finalized my study title, Patient and Family Engagement in Healthcare, a Public Opinion Survey. So the objectives of this study to assess the satisfaction with healthcare service and to gather the public opinion and perception and importance of patient and family engagement to identify what are the barriers and challenges in the patient and family engagement. Now we looked into the methodology of this survey. So we have adopted the quantitative research approach. Cross-sectional research survey design was used and sample was collected in Government Hospital of Nagpur, Maharashtra. And we have included both the IPD and OPD service users. And the estimate sample size was 79 and we sampling technique followed a convenient sample technique. And sampling criteria we have included all the more than 18 years patient and family members who access the government hospital services in last 12 months, and we have excluded who is severely ill and unwilling to participate. So for data collection, we have used structured and valid public survey questionnaire in all three languages, English, Hindi, Marathi. And this questionnaire consists of 5 sessions: demographic information, healthcare services, experience with nursing services, awareness and engagement perception, and engagement barrier and trust. And we have given this question in a Likert scale, multi-responses and open-ended questions. And totally data collected is 79, so through paper-based is 42 and Google Form 37. So research analysis planned on frequency and percentage for demographic variable, Likert scale analysis for experience, safety, communication, and multiple response analysis for prevention barrier, and root cause analysis to identify the low patient safety engagement. So we looked into the result of this survey. So before that, we need to understand the demographic distribution of the participants. So totally we have so the age group average is 29. Majority of participants are female, and they have completed the bachelor degree, and they are employed full times, and they are living in urban and belongs to Maharashtra with their primary focal language of Marathi. And 41% of surveys completed by the patient who have visited the healthcare facility in last 2 times in 12 months, and the 73% survey was given by the family members. Now we see the healthcare experience. To assess this, we have used 20 questionnaires from the admission to discharge. So it was strong performance was given was in health outcome and communication, and low score was in laboratory service. And overall satisfaction was 3.44. It was neutral to high, but still there is a room for improvement in many domains. Now we see the satisfaction with nursing service. It was analyzed through 9 questions, the highest performance in respect and dignity shown by the nurses, and there is a need for improvement in the clarity of nursing explanation, promoteness of nursing responses. Overall satisfaction with nursing service was good, 3.88, but we need improvement in this area. So now we see what are the awareness and engagement perception among the patient. So 84% they felt that engagement is important, and then we ask what are the methods of engagement they need to be involved. So 81 respond they want in person discussion, and 62% they want to be involved in educational and support group activity. And we identify what are the major challenges which prevent the engagement. We have identified 3 major challenges: lack of information, limited time provided, and fear and lack of confidence. And finally we asked how much they trust in healthcare. So it was given as 33%, which was moderate, which is moderate. And we have done RCA for low patient and family engagement, and we have summarized in fishbone diagram with the 5 major issues: communication and information, time constraint, overcrowding, OPD, rush discharge process, resources. There is a lack of patient safety policy, trust and culture, and language and literacy. These are the 5 factors for low patient and safety factor. So to conclude, patient and family recognize the importance of engagement. They report reasonably positive with nursing sense, but still gaps remain in safety practices, laboratory practices, clarity of communication, and consistent responsiveness. They want to be involved in engagement, but there are identified barriers which to be addressed. To summarize, overall engagement was neutral to moderate high. Overall nursing satisfaction was good, but still it needs improvement in clarity of explanation, promoteness of response. Regarding engagement, 83% have felt that it is important to be engaged, but still we need to address what are major 3 barriers which is identified to increase the engagement perception. And there was moderate trust in the healthcare provider. And I like to acknowledge what are the limitations before discussing the way forward of this project. So there is a study was limited to 79% of population, and the study was conducted in only one institute region of Maharashtra, which limits the generalization. It is a self-reported question which may can vary bias. So based on the limitation and findings, I have a way forward recommendation to scale up the study to more government hospitals and regions of Maharashtra, increase the sample size in the phase 2 for stronger validity, integrated the engagement into the hospital safety culture, and implement the target improvements in the lab survey safety practice and promote digital literacy. So now we can take this as a roadmap to strengthen the patient and family engagement, to consider safety and healthier, patient-centric healthcare system. Thank you for your kind attention. Thank you to all.
Thank you so much, sir. Next, we have respected Ms. Margaret Gaurinath, ma'am, ANEI Patient Safety Fellow, Cohort 4, to present their project on patient and family engagement in healthcare, a public opinion survey from the private sector via video presentation.
Of quality and service excellence at Toyota Memorial. Namaste to all. I am Margaret Roy Gaurinath, Cohort 4, serving as Chief of Quality and Service Excellence at Toyota Memorial Hospital, Sierra Leone. I am thankful and honored to address Dr. Michael Ramsey, CEO of Patient Safety Foundation, a visionary leader advocating for zero harm by 2030. I express my sincere gratitude to ANEI for granting us the opportunity to undertake this fellowship. I am deeply thankful to Ms. Tankam Gomez for her support has been crucial in shaping this project. My profound appreciation goes to my mentor, Ms. Pratyusha Chaudhary, whose exceptional mentorship and unwavering support has been instrumental in completing this project. Please give me a minute to pull out my presentation. My project focuses on patient and family engagement, a public opinion survey. The core issue is that patient and family engagement is underutilized in India's private healthcare sector despite its proven impact on patient and quality. There is limited data on public perception around their involvement. This survey addresses that gap to guide future patient-centered strategies. The aim is to collect public opinions and perceptions regarding role of patient and family engagement in private healthcare setting. The key objective is to identify barriers and enablers, to suggest actionable areas for improvement, and informing healthcare policies and practices. The genesis of this project stems from several factors. I was encouraged during my fellowship program session, The Voice of the Patient. Creating a platform for patients and their families to share their experiences and be heard is a critical opportunity for improvement. Low patient satisfaction, many patients and families feel uninformed and uninvolved in their care. There is a need for increased patient safety, reducing adverse events and improving care outcomes through enhanced communication and engagement. There is also a need for data-driven insights. Collecting and analyzing this data will provide a foundation for future longitudinal studies and evidence-based recommendations. A patient's voice is the most important vital signs, as said by Dr. David L. Shake, and this resonates deeply with the foundation of my project. During the review of literature, I did not find any study focused on the patient engagement, but there were several studies on dissatisfaction and satisfaction of patient. The methodology of the project is that the patient and families accessing the private healthcare sector in the studies of Madhya Pradesh were my respondents. The survey covers topic on overall health experience, communication, emergency, lab, pharmacy, nursing, consent, decision making, safety measures, and discharge process. The survey was forwarded through online WhatsApp link. Respondents above 18 years, people who received care in private hospitals of Madhya Pradesh, those who accessed healthcare in the last 12 months, and those who were able to use WhatsApp were included in the survey. And people who were not included are those with cognitive impairment, minors and unable to read English or Hindi. The overview of the PDSA cycle during the plan phase developed a study framework and validated the questionnaire. In the do phase, created a Google form link and distributed it via WhatsApp to individuals and common groups for data collection. The study captured and analyzed respondents' submissions using the Google Sheet. The ACT phase, I will share the outcome with stakeholders and propose a larger, more diverse study for further investigation. This is an insight into data collection screenshots and a few samples of data analysis which was done to find out the result and impact. 76% of the respondents were employed and business. 78% of the respondents expressed overall satisfaction in their healthcare experience. 81% confirmed infection control practices were followed. 79% rated emergency responses as prompt. Laboratory, pharmacy and communication services had a few gaps. Coming to the nursing services, communication and discharge instructions given by the nurses were always clear according to 81 and 84% respectively. Only 62% of the nurses made them feel respected and were treated with dignity. Prompt responsiveness to nurses, to calls by nurses was stated by 74% of the respondents. 47% found nurses were always not available when needed help. Coming to the engagement perception and preferences, 71% rated engagement as important. Only 36% felt involved in decision about their care. Only 57% reported better health outcomes as perceived benefits of engagement. 76% preferred in-person discussion as the mode of engagement. Health literacy, lack of information, and limited time with providers were considered as barriers for engagement. Now, only 33% had complete trust in their healthcare providers, and only 28% were completely confident in making decisions. Thus, the summary is that a survey of 58 recipients of hospital care in Madhya Pradesh's private healthcare sector revealed moderate satisfaction. Key findings include less than 40% trusted their healthcare providers, only 28% felt confident in making decisions. Clear communication and promptness of nurses were appreciated, but 47% of the nurses were not available when needed. Patients preferred in-person engagement. Barriers included limited health literacy, lack of information, and providers' time constraint. Enhancing communication, boosting health literacy, and improving accessibility could strengthen patient engagement and trust in Madhya Pradesh's private healthcare system. The way forward, I recommend to share the study report with stakeholders of various hospitals in the state of Madhya Pradesh to conduct a follow-up study to increase the sample size and strengthen the findings on engagement. I will also conduct webinars for healthcare personnel in MP and other states of the country to disseminate the study findings and highlight their implications on patient and family engagement. I am optimistic and enthusiastic about advancing patient and family engagement. Thank you all for your patient listening and for being part of this journey. Thank you.
Thank you, Dr. Michael. So that is the presentation by the Cohort 4, and the remaining of them had contributed as authors to the patient safety handbook that we have. And this time, the unique thing that was undertaken was to actually understand the patient engagement in private as well as public sector. We are happy to note that we are getting ANEI patient safety fellows from the public sector as well. So that gap is also getting bridged. We know the sample size has been pretty low, so that's why in the next cohort we are planning to extend the sample survey. and we'll try to make it even more robust to understand. But there are some similar stories which are coming out from both the sector, that both sectors are saying that patients need to be engaged more in a manner that they can understand so they can be part of the decision. So that was a finding that came, and surprisingly, we all talk about trust deficit in private healthcare, which was kind of validated though the number of responses were less. So sir, we are going to stop here for a moment and give your comments please.
I am delighted to hear all these wonderful presentations. I think the nurses are the people who've got to create the safety culture in our hospitals, in our healthcare system, and everything I've just heard is related to that. The nurses are involved with safety, they're creating this safety culture, and that's what's going to make the difference. Plus, engage the patients where possible, engage the patients in their own care so they feel comfortable communicating to the nursing staff with their questions and concerns, because the patients are a big part of this team as well. And I think they're nervous when they come into hospital, they need to be welcomed, they need to be shown how they can help, and their nurses have to be open to interactions with the patients, and that's what I hear today. This is what your nurses have been doing, was interacting with the patients to get these studies done, and that's the right way to create the patient safety culture. That's going to make the difference. So I'm very impressed with what I've heard today. I think this organization is on the right track. I think you're going to make healthcare so much safer in India and with your publications across the world. So thank you so much.
Thank you, Dr. Michael. We need you for a few more minutes. Next, we are going to give the completion certificate for Cohort 3. Most of them are not available in person, so I'm going to call out the names. And we have first Lieutenant, okay, certificate has to come. Okay, we have it here. We have Lieutenant Colonel Amita Nays. She's completed her 2 years fellowship, and the certificate is giving digital because during ANECON they actually have a graduation ceremony. That's a repeat one, but their cohort completes now. When you want the technology to help you, that's the time the technology will fail. There? Looking good. Naiman, okay. Sir, give us a second. Okay, so we have Lieutenant Colonel Amita Nays completing, Mr. Abdul Dayan Razak. I put their little photos on the certificate because they are not here, so I thought I should show their faces also. They are from across different states in the country. And Ms. Karishma Kaunt from your own state, she's not able to make it, so she's completing. And Dr. Elizabeth Workey, she's completing. Ms. Pratyusha Chaudhary, you might have heard their names as mentors. So fellowship for you is a 2 years fellowship. The first year is spent in understanding the patient safety as a topic, WHO curriculum they have to understand. Following that 6 months they do a project, and some of the project can run longer, like this, the handbook that we are creating, the safety engagement survey that was done, it will continue. So it is actually growing in nature, the impact that the projects are being taken. The second year, the previous cohort will actually mentor the next cohort. So that's why it takes 2 years. So we ask for that commitment. Only those who can commit are invited to join. Then we have Ms. K.S. passing out, Ms. Rafia Islam passing out, Ms. Jyoti Mary Kancherla passing out. Ms. Krishna Chaudhary again from your own state. I think she's somewhere here. So Krishna, you can join on the stage, please. You are completing. Is she here or not yet? You're here, so please come. At least give her a big hand. She's here in person. Come on. So she is representing all the patient safety fellows who are completing. Stay here. We'll be calling more fellows on the stage soon. And we want to share the cohorts photos. We can have the slides now. यहाँ से वहाँ तक का दूरी कुछ ज़्यादा है। Come here to me. I don't want you to go up and down. Have you got? Yeah. So that is our cohort 3. All of them together passing out now, and that is cohort 4, and you have heard Ms. Margaret, Dr. Davinder, Anuradha, Swarnalata and Tangaraj speaking, and all Dr. Davinder, Dr. Shubhangi, Dr. Professor Geeta Parvanda, they are part of the book that is being written. And I must say the requirement also came from the academicians that we need something like that to help students and faculty, but this book is going to be useful for everyone. It will take some time. But we are very, very happy, and thank you Dr. Michael for giving permission to increase the cohort size. So ladies and gentlemen, we have 30 patient safety fellows inducted this year. So that is a progress for us, and that's a progress for patient safety. So I would request all the fellows who are available from cohort 4 and cohort 5 also join us on the stage, please. And I will ask the cameraman to take a photo with all of us standing with Dr. Michael. We'll spotlight him, we'll stop sharing now. So those of you who are interested to be passionate about patient safety, you are welcome to call us, and we will let you know how you can contribute. And we can stop sharing. Yeah. So I will get down from my phone. So I come back here, you have to bear with me for another few minutes. And Dr. Michael has already left. Thank you very much. So can we move on to the next presentation? We don't need the next. Just give me 7 minutes. So right now I am standing here as a consultant to SCT. You have seen the company SCT outside. I have another cap that I wear. That is, I am founder CEO of my own company, Signe Healthcare, and I consult for SCT. So today, right now, I am doing that role as consultant, speaking on behalf of SCT. I have a short presentation, just give me a minute. I'll ask question. How many of you have heard about Marcy? Please raise your hands. Okay, not too many. Okay. How many of you track Marcy in your hospital? Few more hands, thank you. So I'm going to very quickly go through this. I'm not going to take a full session on Marcy. There is a module of 2 hours that I do online on behalf of ST. ST is convinced that only through nurses we can do miracles for patients. So coming to skin integrity is a huge responsibility for all of us nurses. We know that any breakdown in the skin is a problem for nurses, and mostly the problem happens because we are asked to write incident report. I think I'm not here to talk about incident report. I'm here to say that a fragile skin is a daily challenge for all of us. And we know that we do get a lot of patients who are having fragile skin. It doesn't matter whether they are very young. We talked about neonates today, preterm babies today. They have very fragile skin. Going all the way to the geriatric, and then all the population who are receiving certain set of medications. So we know that immunosuppressants, chemo drugs, certain antibiotics, there are many more medicines, any category of patient when they receive steroids, it can make their skin fragile. So when we use regular tape, there is a possibility that the skin can get injured when we are removing the tape. Am I right? Those who know Marcy, all of you know that it's usually when the adhesive that you have stuck to the patient, when you are removing it, that's the time the skin gets either, some kind of damage happens. Those who track Marcy, how many types of Marcies are there? How many types of Marcy? Some hands spread up. I will take more than 7 minutes if you don't answer. How many types of Marcy? Okay, no problem. Don't worry. The Marcy word itself was coined only in 2013. It's not very old, because when I was a critical care nurse, I used to write skin peeling. We never knew the word Marcy. It came into use in 2013. Dr. Michael, I'm so sorry that I thought you have, left. So I was not able to say bye to you. Sir? Hello?
Yes, this is fine. Hello, can you hear me?
Yeah, I'm so sorry. I thought you have already left. So I would definitely love to say thank you, sir, for your timing. I think it's about 3:30 a.m. there.
Correct, yes.
So thank you
That's
so
correct.
much, sir.
That was a wonderful presentation. Wonderful presentation.
I will be in touch
Students.
with you, sir, for the future activities, and I'll check with you when we are inducting the new cohort also. Thank you so much, sir.
Great.
Thank you. Thank you.
Thank you.
Bye,
Bye-bye.
sir. Bye bye. I'm sure sir must be wondering this is another presentation. I'm so sorry. Okay. So we know that the true incidence of Marcy is not known because it is not getting tracked exactly, and the reasons can be intrinsic and extrinsic, so I don't want to get into that. But I'm very sure you have seen such things happening in our hospital settings. Do we want to prevent them? Yes? I think the children and the neonates and the preterms, they have no voice. We need to become the voice for them. So I think the attitude, when I was also a young nurse, some of the things we used to think, it comes as a side effect of healthcare. Jaan bach gaya, thoda skin gaya, to kya ho gaya? So that's not patient safety, right? We would like to make a difference. So Marcy, this is the latest definition given by Wound Care Consensus. From 2013, there had been different definitions. So this is actually a skin damage, any type of skin damage that can happen utilizing any medical adhesive items. The idea is adhesive, the word. Anything that is sticking, whether it is plasters or dressings, trauma products, electrodes, medicine patches like your fentanyl patches, or wound closure strips. So anything that is sticky, when you put and when you remove, if there is a skin damage, then that is called Marcy. So they can be categorized into medical tapes or transparent films or any kind of adhesive dressing or ostomy supplies. So even your electrodes come into that. So you can see all these things that we are using frequently for our patient care. They can lead to MRSA. So these are some evidence which is available that in ICU the prevalence can be as high as 41%. And if you look at the categories, you can see that almost all of them are looking at ICUs. I don't have any data from India. So you can see that adult ICU, NICU, PICU. So today we are talking about safety for pediatrics and neonatals. So that's what it is. This is summary of some of the studies I could find. So the percentage can range anywhere from 15 onwards to 40%. So this is something that yet to be studied and reported. So I asked you for the types of MRSA. There are 7 types of MRSA. I will not be able to explain to you, but that they are skin stripping, skin injury, tension injury and blister. Then you can have skin tear. There are 3 types of skin tear. Then you have irritant contact dermatitis. You can allergic contact dermatitis. Can have maceration and folliculitis. Now these types I also came to know only when I was preparing the deck. I was not aware there are really 7 types. So it always makes good idea to continue to learn. So these are some of the places where you will use some kind of adhesive, and when you remove you can land into trouble, even the eye patches that you are using. So I will actually show you the next picture is probably the most common culprit in India, though abroad it is not being used anymore. Identify? Dynaplast? Yes? Now nobody wants to say yes also. I do a lot of sessions across the country. I think almost everyone says Dynaplast. Whenever you remove, there is very, very high chance. In my personal experience, anywhere Dynaplast means it was a tension for me, because I know when I remove, if there is any skin damage, I will have to end up writing incident report and explain to someone. And I'm very sure young nurses are also worried about that. It's not the question of worried about incident report. We are worried about whether we can keep our patient's skin safe. That is what is required. Now there is more awareness of MRSA, so they say it is an avoidable harm. If we know how to identify the patients who have fragile skin and what kind of material that we can use on those skin. So this is where SCT has launched this new product. This is your fixable skin sensitive. It is made of silicone, and they have a stall there. So please feel free to go and cut a piece and put it on your skin. You can actually feel the difference. It is not what I say. Go and feel for yourself, and then you will know a regular tape how it will feel, and if you put a silicone, how it will feel, because you can even take it out and put it somewhere else. When I got a sample, I actually put it on my son's hand. His hand is very heavy. I said, can I try? I put it nicely. I said, now I will remove. And you won't believe it, he said, Mama pata bhi nahi laga. So I don't know, this is how he felt. I don't have so much hair, but I know there's a whole lot of difference between any tape that I have used ever and this one. So please go ahead, understand. And one more request I have for all the nurses sitting here. Anything that you use, whether it is a machine, whether it is a consumable, whether it's a dressing, whatever you use on the patient, make an attempt to understand what is this material, what is this made of, what does this consist of, what is this job. Please don't become a nurse who says ki store se aaya tha hum use kar rahe hain. No. You are the patient safety advocate, so you advocate for the patients by understanding what is that you are using. It can be anything. It can be a tape, it can be a dressing, it could be a cannula, it could be anything. And when I was a CNO in Fortis, many a times I understood there was a problem with the product because my nurses told me, ma'am, this is not good for my patient. And I really salute such nurses. Have that courage. We are the voice for our patients, so we must speak up. This is very important. So these are all the characteristics of the silicone fixable skin sensitive. You can feel for yourself after applying when you remove. Do you have any pain, or we call it as a traumatic removal. And all their products are made, they are breathable material. That means it will not allow any moisture to accumulate under the tape. So this is also plus point of fixable skin sensitive. And I really found it, what was really useful was that after I put it one place, I can remove it, put it somewhere else if the position is not right. And interestingly, you can even try to put the tape together. Sometimes it happens, no, it stick with each other. After that, you cannot remove at all. So, but this fixable skin sensitive, you can actually hold it together. After that, you can even separate. So, I don't have any use case scenario because I have not used it myself. I have only tried it on me, and I have not yet had any feedback from any hospital. So we are only sensitizing nurses about this product which is available, and it is for us to know whether this particular product is really useful. If it's useful, please give feedback. And that's how you help any company to create patient safety products. And I am with SCTs because I believe what they are doing, whatever I am doing with them, and they are investing their time and effort in educating nurses across the country. So they have this program called Drishti, Adding to Nursing Excellence. So that's where they request me to do sessions. I do it for them. So thank you so much. Be smart and be kind to our very vulnerable patients, the pediatrics and the neonates who cannot speak for themselves. Let's be their advocates. Thank you very much, and thank you SD for inviting me to speak on the topic. The training on that module is called Saumya. This is an Hindi word, and that's it. Thank you very much, and let's keep our little ones happy despite the fact they have got lines and tapes. Can we do that? Yes. Thank you. Thank you for your patient listening.
Thank you so much, ma'am. With this, we joyfully conclude our Track 4 project presentation. Now it's time to recharge. Yes, it's lunch break. I invite all the participants to head over to the dining area and enjoy your meal. Please be back sharp at 2:15 p.m. because after lunch we dive straight into Track 5 with more exciting session. Have a happy and delicious lunch, everyone.
What else? And how actually? Yeah. Because it's about the use of antibiotic, right? Prescribing antibiotic pattern before and after. This prescribing is done by the physicians, not by the nurses. So how your study can be not significant to the nursing profession or to the nurses? How can you link this from your study?
Before study, the both babies receive antibiotics, ma'am. The post-implementation, we reduced the use of antibiotics.
So, what implementation actually then? It's antibiotic, they are getting antibiotic only.
Here we followed the ICMR standard protocols, ma'am. That we have red flag sign and the yellow flag sign.
Yes.
In the red flag signs, we will start immediately, like sepsis, respiratory distress, and shock. The patients will start immediately.
And in
the
your
yellow,
study, all the neonates,
yes,
I think, irrespective of whether they are having any problem or not, if they are getting the antibiotic, then you have included in your audit. Am I right?
yes, ma'am.
Saraswati, I want to ask one thing to you, that before implementation and after implementation of this SDW, can you tell me about the prognosis of the babies? Like before implementation, the antibiotics were given; those were very high-level antibiotics, and after that, the protocol was followed. So, did you notice about have you included or have you gone through the prognosis of the babies after following protocol, also whether they are recovering well or whatever? Did you notice that? Did you include it in your study, or did you observe? You have not included in your study that we have seen, but did you observe that?
Yes, ma'am, we observed.
Okay, what was the result, like before implementation of SCW and after?
Previously, they will start antibiotic to all the babies. After SDW implementation, they started according to the protocols.
That we understood. but the recovery of the babies, I mean, what I want to ask you, that what was the rate of recovery, it was or it was better, or what was the recovery of the baby? Because you are using, if they are using antibiotics, that is for some purpose, right? So, was the purpose fulfilled in same way or it's in better way? That's what we wanted to know.
The baby hospital stay will reduce more because they start early.
Okay. Please check it. When you go back, please go through the files and check whether already you have told that duration of stay was reduced, but just check it for the recovery. Okay, thank you.
Conference organized by AIMS Guwahati and Association of Nurse Executives India. I am very much thankful for this wonderful opportunity to present my oral paper on the topic From Secure to Unstable, a root cause analysis of post-NICU sudden neonatal deaths conducted by myself, Ashwini KN, tutor and Deputy Nursing Superintendent in AIMS Nagpur, along with Ms. Suruchi, Senior Nursing Officer and NABH Coordinator under the guidance of Dr. Sanjana Somnath, Associate Professor in Department of Neonatology. This study focuses on the sudden infant death syndrome or SIDS, which are catastrophic events occurring mostly during the post-neonatal transition period into the home or in the community settings as well as the hospital settings. It is mostly related to infant-related factors such as physiological immaturity or subclinical sepsis, caregiver-related factors such as the caregiver-related parental fatigue, and some of the system-related factors such as staff shortage, communication gaps, and programs. The objectives of this study were to identify the causes of sudden neonatal death in hospital settings, to correlate the cause and effect of the factors associated with sudden neonatal deaths, and to analyze and develop protocol to reduce sudden neonatal deaths. We used a research methodology of 9 steps beginning from case identification to follow-up and tracking. We first identified the sentinel events of sudden neonatal deaths and collected the related data through incident reports, discharge summaries, and death summary. Based upon the data, a detailed investigation was carried out through the interviews with the healthcare disciplinary team as well as the parents. The cause of death was determined and the contributing factors were identified. A fishbone or Ishikawa diagram was made to identify the root cause, and we developed the action plan. The action plan was documented and submitted to the competent authority of hospital administration, and follow-up and tracking was done with adherence checks. The Ishikawa diagram here demonstrates 4 important factors based upon healthcare team related factors, patient related factors, processes or operational procedure related factors, and protocols or policy related factors. The healthcare team related factors included panic response, lack of refresher training, manpower shortage, and recurrent staff turnover. The patient-related factors include comorbidities such as preterm low birth weight, previous history of hypoxic encephalopathy, acute factors of hypoglycemia, lack of parental education and newborn care, and poor compliance with the instructions by the parents. Some of the process-related factors included suboptimal feeding practices, inadequate protocol sensitization, and deficient guidelines for safe post-sleeping practices of mothers with infants. The protocols or policy-related factors were poor communication among healthcare team, unclear escalation protocol, absence of regular updates between NICU and postnatal ward, and inadequate monitoring protocols for high-risk neonates post-NICU. Based upon this, some of the interpretations made were patient-related aspects such as low birth weight, prematurity, comorbid conditions such as infections or metabolic disturbances, which were the recognized risk factors for post-NICU discharge mortality. The key human factors were insufficient staff, lack of parental education, and poor compliance by the parents, which were also consistent with the global findings, such as the communication and training gaps among the caregivers, which directly impacted the neonatal outcomes. These factors indirectly led to the neonatal mortality after transfer of the newborn from the NICU to the postnatal ward. The analysis also included some of the operational challenges such as the suboptimal feeding practices, inadequate protocol adherence, etc. Through this root cause analysis, we identified the strengths and some of the corrective and preventive action. The strengths identified through the root cause analysis were the critical thinking and quick decision making of the healthcare team, particularly the nursing officers, who were able to initiate the pattern mass ventilation immediately after the unit collapse. The corrective and the preventive action taken by early newborn screening, which were made as a priority in NICU, regular monitoring of the PNC newborns, not only by the neonatologists but by the obstetricians also in the postnatal ward. Revision of the NICU transfer protocols, perinatal mortality review meeting were initiated regularly with the interdepartmental collaboration. And also establishing the nursing rounds, especially during the night duties, in order to monitor the safe breastfeeding, burping, co-sleeping, and evening events. Then some of the administrative actions taken were mandatory and regular neonatal resuscitation, training of the healthcare team members, reinforcement of the parental and caretaker education, particularly on sudden infant death syndromes in regional language through appealing AV-AIDS, routine sharing of the duty roster or communication regarding the availability of resident doctors in the postnatal ward, and availability of the duty telephone communication for better handoff, especially during the night rounds, and also meeting the staff shortage in critical areas. Through this analysis, we indicate some of the patient safety guidelines such as the parental and family education, reinforcing the structured training, safe sleeping practices, etc. Environmental and equipment improvements such as developing the resuscitation base, improving the lighting and monitoring facilities, maintaining the neonatal resuscitation kits, etc. And through governance and review meetings such as conduction of the regular perinatal mortality reviews, developing a robust audit and feedback loop. The other implications through this study are staff training and protocols based upon neonatal resuscitation, simulation drills on handling the unresponsive neonates in the wards, developing clear protocols on monitoring high-risk babies post-NICU transfer, safe handover and escalation pathways, emergency communication between ward staff, NICU and PNC residents. The system strengthening implications included establishment of 24/7 duty communication phones, standardizing the early newborn screening, ensuring NICU oversight continually even after the babies were shifted to wards, and also exploring the increasing staff to patient ratio. In conclusion, through this paper, we would like to implicate the patient safety guidelines to the newborns so that we would develop quality newborn care in institutions. Thank you again for the opportunity.
মাইক্ৰফোন কোনটো কাম কৰিছে এইটো নহয় এইটো নালাগে এইটো মোৰ মাইক যেতিয়া মই কথা
Thank you, ma'am, for sharing your valuable insight. Moving on, our third research paper will be presented by Madam Ms. Rekha Gali, Nursing Superintendent, Mumbai, via video.
I would like to thank the organizer ANEI and AIMS for giving this opportunity to present my paper. My name is Rekha and I will be presenting my paper on strengthening child health through family and community engagement. Evidence from a survey of parent and community health workers. Introduction. The study aims to investigate the impact of family community engagement on enhancing child health, especially emphasizing parental knowledge, active participation, and the role of community health. The study employs a quantitative approach to examine the correlations among awareness, engagement, preventive practices, and personal health. India, the world's second largest country, has a population of 1.21 billion and an estimated 26 million children born annually. However, despite an increase in the population between 2011 and 2011, there was a 5.5 million reduction in the child population aged 0 to 6 years. This represents a 3.1% reduction in the total number of children aged 0.6 compared to the 2001 census. Objective of the study is to assess the level of awareness, participation and involvement of parents, caregivers and community health workers in child health practices, and to examine the impact of family and community engagement to improving health outcome and preventive practices in child health. Hypothesis. H1, there is a significant relationship between awareness level of parents, caregivers and their active engagement in the child practice. H2 is community health workers' involvement significantly influences the adoption of preventive health measures by families. And H3 is higher level of family and community engagement are associated with better perceived child outcomes. Going forward, I would like to tell you about the literature. Several studies have highlighted the importance of family and community engagement in improving child health outcomes, such as parental involvement, role of community health worker, family-community partnership, and impact of child health indicators. Studies have consistently shown the way parents are informed and actively engaged in their child's health, such as ensuring timely immunization, proper nutrition, and hygienic practices, child health outcomes improve significantly. So evidence also highlights the vital role of community health workers. They act as a bridge between health facilities and the families, providing education, guidance, and follow-up care that strengthens the child program. Methodology. The study examined how family and community participation improves child health using quantitative methods. Parents, caregivers, and community health professionals were studied to understand awareness, preventive strategies, and health outcomes. Conceptual framework. The conceptual framework shows the proposed connects among the principal variables in the study. The hypothesis suggests that the awareness of parents and care H1 positively affects their participation in child health practices. The study results provide empirical inferences based on survey data collected from parents, care, and community health workers. The section presents an overview of the demographic attributes of respondents, succeeded by the assessment of reliability and validity of the constructs employed in the study. Demographic variables. The demographic file of the respondents indicates the balanced gender represents with 55.5% male and 48.5% females. The age distribution is rather uniform among the three groups. The investigation of the construct in this study indicates strong internal consistency and convergent validity. Hypothesis: awareness level of parents, caregiver, and active engagement in child health practices, community health worker involvement, adoption of preventive child health measures by families, family and community engagement, perceived health child outcomes. The study's findings highlight the essential importance of family and community involvement in enhancing child outcome. Conclusion: enhancing child health through multi-tier engagement strategy. Families, cares, and community health workers play a complementary role in promoting proactive health behavior. Parental knowledge promote proactive health behavior. Community health workers assist in implementing preventive care. Collective involvement improves children's overall health and well-being. Implication of policy and program development, emphasize on health education, enhance community health workers' ability and participatory health initiatives. References and with this I come to the conclusion of my presentation. I would once again like to thank the organizers and the audience for giving me this opportunity and for your kind information. Thank you so much.
Thank you, ma'am, for your contribution. With that, we conclude the research paper and now we proceed to quality improvement project. To announce the respected jury members for QIP, Madam Geeta Datta, any members? Madam Papuri P. Chaudhary, ANEI members, and Madam Krishna Chaudhary, ANEI members. To begin, I would like to call upon Madam Ms. Maitri Sarkar, Senior Nursing Officer, Infection Control, RTIICS, Kolkata, to present her quality improvement project.
Good afternoon, jury members, and good afternoon, everyone present here. I am Maitri Sarkar, presenting on behalf of Hospital Infection Prevention and Control Team of ANEI Kolkata. My QIP is strengthening roadmap of infection control practices, a critical step to prevent and control healthcare-associated infection for safer outcome. For the problem statement, healthcare-associated infections continue to be the major challenges globally. They increase the patient's morbidity, mortality, and hospital stay as well as cost of the care. Despite of existing infection control measures, we found gaps in consistent implementation of healthcare infection control practices in pediatric care unit and neonatal care unit in our setting. Internal audit and gap analysis confirmed that we needed a stronger standardized roadmap for infection prevention and control. So the quality improvement project initiated for this is actually a initiation from infection control and infection prevention and control team, ARTIX Kolkata. The aim of this project is to improve clinical outcome in pediatric care by strengthening infection prevention and control strategies, particularly early recognition of sepsis using Phoenix score. So in morning already we have seen that PUS is the commonest scoring system which is being used in different neonatal care units. It is Phoenix score is basically a upgraded version that I will come. So objective of our quality improvement project is implementing Phoenix score with alarm notification system for timely escalation, strengthening environmental cleaning protocol, developing pediatric infection control training module with goal of 90% improvement in knowledge and 85% compliance in practice audit. So in practice audit we have taken hand hygiene, appropriate use of personal protective equipments, and we have taken aseptic technique. These three areas were taken within consideration. So within the background of this study, actually historic data has been given to compare the data for the background. From the November 24, it has been seen there is an increment in infection control. Then we could go for a literature review where it has been shown that risk factor for healthcare associated infection among children in low and middle income country, which speaks that incident is 17.9%. Now this data is actually published in 2011, so it is a quite older data. After that, we couldn't get a specific data for neonatal care unit and which gives the appropriate data on healthcare associated infection only. So the previous information was escalating. We used to use this CHIUS is the scoring system which has proven suboptimal to escalate the early sepsis because no cases as such established. In my hospital, the setting is dependent on cardiovascular system. And most of the patients come to us are either congenital heart disease, they undergo a surgery, and within the stay they used to be within the pediatric intensive care unit or neonatal intensive care unit mostly. Now lack of knowledge regarding the infection prevention control within the different healthcare worker where mean scoring has been taken. 3 different areas has been selected for healthcare worker is like doctors as a separate knowledge assessment has been given, for nurses another assessment, and for housekeeping staff another assessment. So 3 which mean we have taken as 11 and for 66% of the healthcare worker doesn't go for a training within last 12 months. That was 3 identified problems which we have rather plotted after that. Once we deep dive within the problem, then root cause analysis has been done with the fishbone analysis. We have identified several factors. The list has been shared with the 7 experts for ranking. After ranking from the 7 experts, we have selected top 3 problems, that is prompt cohort on basis of Phoenix scoring system and staff awareness and knowledge on infection prevention and control practices and environmental cleaning. And according to this problem, we have structured a process roadmap to reach our goal. So we have used PDCA cycle and planned our intervention accordingly. Within the PDCA cycle, actually we have introduced Phoenix score. Phoenix score, the difference between Q's and Phoenix score is, I just want to sum up. In respiratory system, we used to use tachypnea. But in Phoenix score, we used to have FiO2 and PO2 inclusive, so more comprehensive result can be shown when the patients are intubated. And for cardiovascular, the other Q's or Q's, they used to use blood pressures and heart rate. What we use in Phoenix score is MAP and vasoactive substance, use of vasoactive substance. So this is more intensive, and the foremost things which could be identified is platelet count. Anticoag use of platelet means we got most of the patient, this is the assumption, it was not included within the study. We have seen most of the patient escalated on basis of platelet count, which has been degraded, and after that, because it is a cardiovascular system, most of the time we couldn't got a escalation on the basis of Q's. So before project data and after project data were compared within the scoring systems, we got an early identification of sepsis within half an hour on the basis of Phoenix score, which is more than 2, and 100% compliance we could get within next 2 months. So the implementation started on February. We could start adopting data from March. It was 14.3, then 40%. Then in May onwards, we could get 100% compliance on appropriate escalation. These all are the identified sepsis from the Phoenix score. And for the HCI rate, you could get a difference. It has a steady downward, it shows a steady downward movement. And a random infection, environmental swab was positive on a single location, which has been shown, because before that it is a schedule system is there in our setup, which is bi-weekly environmental swabs are being sent. For air cultures, settle plate are being sent, and water culture, we go for water microbiology bi-weekly. So we went to these all things afterwards also, and this time with March onwards we informed infection control nurses to take the swab so that there is no bias. And our target 85% knowledge we could get in improvement as it is showing, and compliance to the practice post training has been 90% in all practice audits, and training attendance, though it was not inclusive within the preliminary section, 100% training attendance we could achieve. So the awareness program of the personalized IPC, given this, actually this, why we have included within this, because we have tried roles and specific role and role identification has been done for each type of personnel within the type of IPC module. So specific IPC module has been created for the healthcare worker category, and which has been started. Now every quarterly we are going through this for the same. So the whole program has been projected on DMAC project summary I have given. So in D, first 15 days was started. First meeting was done on January 21st, and it has ended in February 5. And the measurement we have started taking from 6 to 22, and analyzation phase was 21.2 to 7.3, and in improvement phase it is 8.3 to 8.6, and in control phase, so just now we have finished our control phase, and after this control phase, as I have told that we have taken only top 3 problems, we will try to initiate other problems, we will try to integrate other problems too within the QIP. So it is a continuous process what we have started. We will try to incorporate the other things so that we can go on serving the best patient outcome. These all are the references. Thank you.
Do we have time?
Sorry, extremely sorry.
Do we have time for question? Or at the end of the session? One question. Okay. Congratulations, Ms. Maitri Sarkar. That was a nice presentation. Just a question from my end. What are the challenges you have faced during your QIP and how did you overcome that challenge?
Ma'am, first of all, challenges from my point was I am an infection control nurse from the institution. First of all, it was everyone wants to finger out others. So healthcare, within the healthcare personnel, there was no as such coordination. So that was missing, and that thing could be introduced once we have specified modules, because the modules were same for everyone, which couldn't give them an appropriate role specification. And by virtue, we get HICC chairperson, who is clinical director of our hospital, so we get every support from him. So that was one point challenge solution for us. And from our angle, beforehand we used to work separately, but we could start working, it is more coherent.
Thank you.
Thank you so much, ma'am, for your presentation. Next, I invite Madam Ms. Vaya Suklandan, Shift in Charge, NICU Department, Supercare Hospital, Shillong, to present her quality improvement project.
A very good afternoon to the jury members and also to everyone present here. I am Vayasuk Angdan, representing Supercare Hospital on the quality improvement project. And the topic of my project is improving early initiation of breastfeeding among normal and LSCS deliveries. The reason why I chose this topic for my project is, even though we all know that the WHO recommendation is that early initiation of breastfeeding should be done within 1 hour, but in the hospital that I've been working, there has been a delay that we have collected the data and we have found that there has been so much delay, and that's the reason that I've chosen this topic today. The problem statement that we have found out is that there has been a delay in the initiation of breastfeeding among normal and LCS deliveries. And the main aim is that to focus on early initiation within 1 hour of all deliveries. So the total samples that I've collected is 195 samples, out of which we have found out that in normal vaginal delivery there has been a non-compliance of about 41%, and the average initiation time was 56.47 minutes, and in LSCS there has been around 100 non-compliance with average initiation time of 131 minutes, and this can be achievable with realistic training and accurate protocols, and also this is relevant linked to neonatal outcomes and global WHO recommendation. The time that I've taken to complete this project was from January 2024 to July 2025. Coming to the background and baseline data, as we all know that breastfeeding is a cornerstone of neonatal survival, growth and development, and it is also recommended by the WHO that all neonates should receive breastfeeding and should be initiated within 1 hour of birth. And it also proved that it reduces neonatal mortality, enhances mother and infant bonding, and also provides essential immunological protection to the neonates. But despite knowing all this, there has been a few barriers that we have faced, that is such as limited staff awareness, absence of standardized protocols, inadequate maternal counseling, and also post-operative delays, especially in LSCS deliveries. So these factors have significantly contributed to the delay of early initiation of breastfeeding. So a baseline audit that was done at Supercare Hospital, we have found out that in normal vaginal deliveries, there has been 41% non-compliance, and in LLCS, there's about 100% non-compliance. So this has showed that there has been a huge gap and a need for quality improvement project. Hence, using the PDCA, we have done this project. We have also done a root cause analysis using the fishbone analysis, and we have found that there has been 4 factors that has been contributing to the delayed breastfeeding initiation. The first being patient-related, immediate post-operative pain of mothers post-cesarean. Then rural families were hesitant due to cultural myths, as it was believed that there has been a myth in our state that colostrum is bad for the babies. So some families stick to that myth till now. And psychologically, some mothers were not ready to breastfeed due to their own conditions. Some of the practices that we have found out that OT recovery room protocols were not available, and also some newborns were shifted directly to baby room, as in our state the weather is very cold. So in order to maintain euthermia, some babies were shifted directly to NICU, to baby room, as there was no standardized protocol, and also because there were unavailability of a radiant warmer in the recovery room. And also, coming to people, there was staff hesitation in the OT recovery room. Some staffs hesitate to initiate breastfeeding immediately, as they have less awareness of early initiation of breastfeeding. And also some staffs have recently lacked advanced training, and also there was low staffing during the night shift and the day shift, and this causes reduced support to mothers in the recovery rooms. Also, some of the organizational factors are staffing variations between day and night, and also limited structure support in the OT recovery. So some of the interventions using the PDCA cycle that we have done in January to May 2024, we have found out that there was a non-compliance of 41%, with the average initiation time of 56.47 minutes, and in LSCS there was 100% non-compliance with average initiation time of 131.92 minutes. And the issue that we have noticed here in LSCS deliveries is that recovery room protocols were not clear. Then staff hesitation in the OT recovery, post-cesarean and post-condition of the mothers, and also immediate post-operative pain of mothers, so they do not want to breastfeed the baby immediately. And also they are psychologically not ready to breastfeed the babies, and some babies were shifted to baby room immediately. Then in June to August 2024, after we have noticed these issues, we have introduced a standard checklist for OT and recovery nurses, where babies with ACAR score of more than 7 were not shifted to baby room or to NICU, but they were kept in the OT recovery, where we have provided a radiant warmer within the OT recovery room. And also we have trained a few nurses and some anesthesia technician in order to promote skin to skin between mother and the baby, and also assisted in matching. And also we have piloted some staffs for early initiation of breastfeeding, with nurses' assistance to the mothers in helping them to initiate early breastfeeding. And also we have strengthened antenatal counseling for mothers during their antenatal checkup. We have given them antenatal counseling, and especially for elective LSCS mothers. So after we have intervened all these interventions, we have found out that in September 2024 to Jan 2025, there has been a decline from 41% in normal vaginal delivery. It has come down to 9.1% with the average initiation time of 28 minutes. And in LCS, there has been a drastic change from 100% non-compliance. We have come down to 81% non-compliance with average initiation time of 67 minutes. And we have also decided to further strengthen the recovery room practices. But after all these interventions, we had to do a PDSA cycle too, because we have still noticed there were still a few areas that we need improvements, such as the night shifts and low staffing patterns, and also lack of knowledge of newly recruited staffs. So we have developed a breastfeeding initiation policy, which was adopted by the hospital management. And also we have introduced a monthly quality indicator tracking of early initiation of breastfeeding. And also we have assigned breastfeeding champions among seniors so that they can mentor and monitor these new staffs in order to help the mothers breastfeed even in the recovery rooms. So in February to July 2025, we have did an audit again, and we have found that in normal vaginal deliveries, there has been a non-compliance and increase in non-compliance of 18.1% with the initiation time of 40 minutes, sorry, it is an error. And LSCS, there has been a non-compliance of 58.8% with average time of 58.1. The reason for this non-compliance in normal vaginal delivery is because some babies were shifted to NICU because their upper score were less than 8 and they were sick babies, so we had to shift them directly to NICU. After this study, with the help of our pediatrician, we have initiated a breastfeeding information booklet for antenatal mothers and families, and also we have distributed kangaroo mother care handouts. So we can see from the graph here, we have come down from 100% non-compliance in LSCS, we have come down to 81, and we have reached 58.8 with the median being 80. And in normal vaginal delivery, non-compliance of 41, we have come down to 8%, but there was a peak of 18%. And resident time initiated, from 131 minutes in LSCS, we have come down to 67 minutes, and we have come down to 59 minutes, that is almost less than 60 minutes. And in normal vaginal deliveries, from 57 minutes, we have come down to 28, but there was a peak increase to 40 minutes. We have also conducted a t-test on assessing the staff knowledge regarding early initiation of breastfeeding, and we have found that after the intervention, the post-test score has increased compared to the pre-test scores. These are a few of the pictures of the interventions that we have done, such as launching the booklet in both English and also our local language, and also assisted mothers in breastfeeding. This is the protocol that we have used in our OT recovery rooms, and also the post-test and pre-test that we have conducted. So in order to conclude, we know that early initiation of breastfeeding is achievable even after LSCS with clear protocols. Breastfeeding champions can also help to eliminate the hesitation of staffs and also to improve the compliance, and also antenatal counseling can help mothers and families to adopt to early breastfeeding initiation. And also policies and checklists can also be replicated in the labor room, OT and baby room, and also monthly nursing quality indicator can also help in tracking and also help in enable continuous monitoring. Family-centered education can also be given. And also hospital-approved breastfeeding initiation policies can also ensure long-term adoption, continuous monitoring, orientation of new staffs to maintain practice standards, and also peer champions and audits can also help to reinforce and sustain improvement. The next step is that we have strengthened the recovery room protocols to further reduce LSCS delays, engage community health workers to eliminate the rural cultural myths, and also we have explored integration of early breastfeeding initiation compliance and hospital accreditation. So to summarize this, QIP has also enhances patient safety by ensuring a timely initiation of breastfeeding, which also helps to reduce neonatal mortality, prevents hypoglycemia, lowers infection risk, and also promotes optimal growth. And also with standard protocols training, also helps to minimize delay, reduces iatrogenic risks, and aligns with the WHO recommendation. These are the references that I've used. Thank you.
Ms. Baisutlang, this is a very wonderful project. I have one question to ask. What you have done for the mothers who is severely ill and the newborns, those who are hemodynamically unstable, for them what protocol you have maintained?
Ma'am, we have decided that, as you've seen in the non-compliance, that sick babies were also put in that criteria. So we have decided that sick babies will be placed in the exclusion criteria if we further continue this project.
Thank you.
Thank you, ma'am. Thank you.
Thank you, ma'am, for your excellent work. And finally, we have Madam Ms. Vincy Sunil Thomas, Senior Nurse Educator, Fortis Mulund, Mumbai, who will be presenting her quality improvement project through a recorded session.
Hello everyone, this is Vincy Sunil Thomas, Senior Nurse Educator from Fortis Hospital, Mulund. And let me begin by thanking ANEI for giving me this opportunity to present my study. Let me share my screen. So my QIP is on impact of improved compliance to breastfeeding on reduction of hospital readmissions among neonates in a multi-specialty tertiary hospital. My aim was to reduce the number of preventable hospital readmissions among neonates to an absolute zero using strategies to improve compliance to breastfeeding in the hospital by June 2025. The background data showed that readmissions rates among neonates was an increasing trend. In our hospital, on an average, we have around 25 neonates getting discharged from the ward. In June 2024, we witnessed 4 neonatal readmissions, which was highest in a month. So it was around 16% of neonates getting readmitted, and this was due to preventable events like hyperbilirubinemia. So history collection, clinical examination, and lab findings of these neonates indicated lack of effective breastfeeding by the mothers as one of the reasons. Breastfeeding practices were then audited across the units, and there were multiple areas for improvement that were identified, including increased dependency on formula feeds by mothers. We conducted a survey among mothers visiting the OPD for follow-up among 33 mothers, which revealed that only 24% were exclusively breastfeeding their babies, with 67 providing formula feeds along with breastfeeds, and 9% purely on formula feeds. We also did a root cause analysis on finding out reasons for these increased neonatal admissions further, which showed that among people, that is mother, there was inability to identify danger signs among the neonates. So they kept watching over the neonates at home, which led to some risk factors, and they had to be admitted. Then lack of awareness regarding indicators of feeding adequacy. Among staff, we realized there were ineffective antenatal and postnatal counseling, less time spent with the mother for lactation counseling, ineffective discharge instructions, and disregarding psychological concerns of the postnatal mother. Among processes, there was a lack of standardization of protocols and no emphasis given for importance of breastfeeding. And in the environment, we had lack of mother support systems, and then patient preference, that is formula feed, was adopted as a standard practice, and all departments were working in silos. There was no role clarity on who will support breastfeeding. So we intervened in two phases. Phase 1, which began from October 2024 onwards, where we thought of strengthening the existing antenatal and postnatal counseling practices, skill building of healthcare providers, and initiation of breastfeeding within the golden hour. For that, we started with ANC sessions twice a month, addressing smaller groups, one-to-one counseling, initiation of the patient information leaflets, mother support groups, and also introduction of galactobooks for all postnatal mothers. We introduced one lactation nurse per shift in the maternity unit with round-the-clock monitoring of patients. Clinical psychological visits were initiated for all postnatal mothers, and the initiation of breastfeeding within golden hour was started for both normal delivery as well as cesarean section deliveries on table. So this brought about improvement in the participation of mothers in breastfeeding, and thereby increasing in percentage of exclusive breastfeeding on discharge. Lactation nurses could ensure skin-to-skin contact and timely breastfeeding, and competency among healthcare providers helped in timely escalations and maintaining the golden hour. That is, initiating breastfeeding within 1 hour of delivery helped in improving breast milk production also for the mothers. So all these were implemented, adopted as a practice. Then in phase 2, Jan 2025 onwards, we also thought of standardizing all our guidelines and pathways to administer scientific and predictable care to the patients. For that, we brought about this labor and delivery preparedness flow chart, which was displayed in the labor OT, so that there is emergency preparedness among staff. Then the LCS care pathway was revised. It was made user-friendly and easy to follow format. And lactation bundle was introduced, which helped the healthcare workers to encourage breastfeeding both through antenatal to postnatal period of the mothers. Then baby well-being card was introduced so that the parents on discharge could track the well-being of the baby and escalate to the pediatrician as required. All these processes were initiated and audits were done and improvements were made, and standardization in provision of care was achieved between all the multidisciplinary team. So these processes were also adopted. You can see pictures of intervention. We have the PIL materials, then encouraging letter to the mother, the pathway, the LCS, the L&D preparedness checklist, the baby well-being card, the lactation bundle, and the ANC sessions along with a caring dad certificate to support breastfeeding for the dads. You can see the results and impact here, the type of initial feed after 2 phases of our project. We could see an improvement in the use of breastfeeding as an initial feed, which improved from 40% to 80%, and breastfeeding days, which refers to number of days the admitted infants receive only breastfeed. It increased from a total of 16% to 50%. Average time to initiate feeds, it improved from start of like 62 minutes to, it came down to 36 minutes to initiate feeds. And also exclusive breastfeeding on discharge, the percentage, we still have scope of improvement, but definitely we maintained it above 65%. And the main outcome, that is readmission among neonates. So the preventable readmissions because of hyperbilirubinemia and dehydration also came down to an absolute 0 from June onwards. Even August there was there was 0 readmissions. So in conclusion, I would say that these even major corporate hospitals can adopt breastfeeding as an important practice and bring about improved outcome among the patients. And for sustainability, we incorporated compliance to breastfeeding breastfeeding initiation with golden hour, exclusive breastfeeding on discharge as department quality indicator, and rate of readmissions of neonates were also tracked by the quality. So in summary, I would like to encourage the community that to incorporate breastfeeding, whichever hospital you are, but it will definitely impact the lives of neonates. Thank you so much.
Thank you so much, ma'am, for your contribution. I also extend my thanks to our respected jury members for your time and support. Thank you so much, ma'am. With this, we conclude track 5. A big thank you to all our jury members for their time, guidance and support in evaluating and also special thanks to all the presenters. We now move forward to track 6 of our conference. The theme of this session is Diagnostic and Medication Safety in Pediatric Care. We all know that caring for children requires the highest degree of vigilance, precision and responsibility. Even the smallest errors in diagnosis or medication can have profound effects on the young lives. This session will shed light on strategies to enhance safety, minimize errors, and strengthen systems that safeguard pediatric patients. To lead us into this crucial discussion, may I now invite our esteemed chairperson, Madam Ms. Pinky Bayan, Ms. Pinaki Bayan, Chief Nursing Officer, Apollo Hospitals, Guwahati, and Apollo Excel Care Hospital, member in ANEI. I welcome you, ma'am. I also invite our respected panelist, Madam Dr. Rashna Das Hajarika, Senior Consultant Pediatrician, Guwahati, Madam Dr. Parul Datta, Retired Principal Nursing Officer, West Bengal Government Nursing Services, and Madam Lieutenant Colonel Vasundhara Pal, Nursing Officer in Charge, OT, INHS Ashwini Mumbai, member ANEI, to take the stage and share their insights. Let us all welcome them with a warm round of applause.
And very happy to be in this auditorium, and thank you ANEI and organizing team for organizing such a beautiful forum. But to be very honest, I don't know what to say. Just now seated here with such a bad news and not able to really talk any sentences. And I think all of us, we know he is one of the person to whom I don't know how to go ahead with this session. But anyway, we need to continue our job, and then I hope any member has arranged some, kind of condolence maybe soon after this program. And yeah, so once again, let us come back, because I understand nobody will be able to concentrate being from Northeast, but then it's important to learn, and so must go on. That's a dialogue, we need to do that. This particular moment, it's a really a moment to talk about patient safety, and we observe patient safety week. Now we are talking about month as a September, and also the day was 17 September. Today, 19 September, we are discussing many important points, and one of the important track probably we have to really look at very differently, that diagnostic and medication safety in pediatric care. So far we talked so much about adult care, but then I think this year that team itself talked about newborn and children care. With that, yes, I'm very privileged, to be honest, allowing all of you to introduce such eminent personality who are with us as a panelist. To start with, if I have to talk about most senior person, with us, Dr. Parul Datta, ma'am, it's a profound gratitude, and very fortunate to be with you at Guwahati. We Guwahatian and Assam Northeast people, maybe we all know about you because we read your book, and whenever we talk about Parul Datta, it comes as pediatric, So we are so privileged to have you here, ma'am, and your input towards safety of children in terms of these two aspects. One is the diagnostic error, and other one is the medication error. So I will be very happy if at all you can proceed for your presentation, ma'am.
Okay, thank you, madam, for my introduction, and thank you everyone for being here. I think I am having some slides. My slides can be shown? Excuse me. So, anyway, thanks to ANEI and the organizing team for giving me this opportunity to say something regarding the safety, patient safety, especially for the newborns and for the children. So regarding the diagnostic safety, so we can say most important thing, it is critical and crucial for the patient safety to maintain the diagnostic safety, especially for the neonates and children. And next slide, please. So welcome. And there is, we know that there is various diagnostic interventions that can be invasive or non-invasive. And from the basic study of our nursing curriculum, we know that for the diagnostic evaluation, we have to collect the medical history in details. We have to do the thorough clinical examination. We have to collect data related to laboratory investigations, especially from the blood and other body fluids. And we have to perform, now we are in the technological era, so we have to perform so much technological diagnostic evaluation through using the technology. So with these only, we can come to a conclusion and maintain the safety for the patient, considering the hazards of these diagnostic interventions. So next slide, see we know that improvement of diagnostic process is very critical, and we have to maintain the safety of the patient, and we have to prevent the diagnostic errors and harms during our diagnostic evaluation process. What are the diagnostic errors we found in the clinical area for the old patient? That is mainly the missed diagnosis or delayed diagnosis or over-diagnosis or wrong diagnosis, or sometimes not doing any diagnosis, especially in the rural population and where the facilities are not available. So from the Western data, we can find out that about 60% of the patient harms occurs due to the diagnostic errors. And that occurs due to missing details of the medical history. We don't have the healthcare provider and personnel, so we don't have that much of time to collect details of medical history, especially the huge population of the pediatrics group. So that's why the medical history missing. And family members, they are not able, sometimes they are not able to understand what information to be given to us and what not to be given. And we are also in hurry. So that's why medical history, if it is not taken, then there will be no proper diagnosis and there will be diagnostic error. And another important area is clinical examination, especially in emergency situation, in triage bed. Sometimes the medical professional, doctors and nurses are doing a quick clinical examination, and that missed so many important points, especially the newborns and children. Those are not able to speak themselves and their problems quite clearly. So another important is lack of communication, inefficient communication and equipment failure, lack of well-trained personnel. Even technicians are also not well-trained about the use of technological equipment. So with these, there are so many diagnostic errors, and this is our commitment to reduce the diagnostic errors and to prevent the harms for the patient, newborns and children. So in the next slide, I'd like to highlight about the challenges of pediatric diagnostic safety. The major three challenges. First is the changing anatomy, physiology and developmental variability that present a most important challenge. The newborn's anatomy and physiology and pathophysiology is totally different from that of older children and adult. So we have to be very much thorough about this changing anatomy, physiology, developmental variation and pathophysiology. Then only we will be able to diagnose safely. And another important point and challenge is that young infants and children, their signs and symptoms are non-specific. All the illness are having common signs and symptoms, and that makes us confused during the diagnostic evaluation process. So, and sometimes not only the young children, neonates and young infants, they are not able to articulate their symptoms due to their limited verbal communication. So we have to be very good observer to find out the signs and symptoms and clinical manifestations, because the children, they are not able to say what problems are they are having. So this is a most important challenge for the diagnostic safety. Another huge and high workload of huge pediatric population with huge pediatric illness, and those are there are so many preventable aspects, but till now they are the most sufferer. And the lack of access of complete health records. That even if records are available, the computerized records are not available in our country, especially in the rural area. Even in the public sector, it is very difficult to get all the records for the children. If the children are coming for the second visit, we are not able to find out all the data. Another non-availability of the modern facilities is also another challenge, and frequent interruptions during the process of evaluating process, that also may give us some challenge for diagnostic safety. So what strategies we have to follow to overcome these diagnostic challenges and safety? First, we know from the very beginning morning we are listening about the involvement of the family members and parents, and for the older children also, we can engage them. Comprehensive data collection for the diagnostic journey, for history, physical examination and laboratory investigation, radiological imaging, that should be done. Health workforce must be skilled with their cognitive, preventing the cognitive errors by the training and continuing education program. That is very important. We have to be very much up to date, and that's why this type of continuing education program, conference and workshops are very important. And we have to follow the standard guidelines for diagnostic evaluation and communication protocols. And we have to follow the standard quality improvement project for the safe diagnostic evaluative process. We are now following not the quantitative service for the competitive population. We have every point of care, we have to follow the quality improvement, and then add diagnostic technology with precautions. Like whenever we are using the CT scan, there can have radiation hazards. Whenever we are doing the repeated blood sampling, there can have some, especially for the newborns, like they can be sufferer from the infection or the less blood related problem. So that we have to consider that aspect also. Then now we are in the not only in the technological era, we are in the artificial intelligence era. So we can take the help of the artificial intelligence for decision making regarding the diagnostic process. Another strategy, what we are in the emergency situation, we have to take most important how to manage the emergency situation. That emergency medicine is now a emergency as in a new subspecialty. So we have to learn how to manage the emergency setting, and we have to follow the checklist and decision support tools and multidisciplinary collaboration and some expert consultation, team approach we have to follow for diagnostic safety and prevent the diagnostic error. And point of care testing, now we are giving more emphasis on the bedside X-ray, portable ultrasonography, and the screening protocol for the newborns like ROP, OE, hearing screening, that is OE, VERA, and pulse oximetry. With the simple pulse oximetry, we can identify the critical congenital cardiac heart disease. So other than that, with IEM, inborn error of metabolism, this screening protocol helps to detect the disease condition early. Congenital anomalies under the RDSK protocol, we can follow this diagnostic approach also by screening. There are standard protocol in the Western now, we are in our country also, that is congenital hypothyroidism, then congenital adrenal hyperplasia, G6PD deficiency. This type of diagnostic screening protocol we can follow for the early diagnosis. And most important is, for doing all these things, we need funding and we need advocacy. Newborns and young children are the innocent victim of all these different disease patterns. So it is our responsibility to do the advocacy and funding for research and training, for early identification, to prevent diagnostic error, and to also foster the family-centered care and community involvement to improve the health literacy. So these are all about my diagnostic safety thinkings. So for diagnostic excellence, we have to reduce the unnecessary testing and overdiagnosis, and we have to promote the diagnostic stewardship. Everybody should be aware about this, and we have to prevent the misdiagnosis and overdiagnosis. Thank you regarding diagnostic safety for the preventive population. This is all about my thinking.
Wow, such a elaborative discussion.
she has brought to the forum. Thank you so much, ma'am. You have put across so many points which are so important. And to me, there are some catchy words. One is the prevention of cognitive error. I think this is the way we need to look at, and we need to have a lot of training on the subject, and we can eliminate those errors probably. Number one, ma'am has mentioned we are in an era of technology. We need to utilize artificial intelligence, the process towards how to deal with the problem. More importantly, I think we can prevent by having a lot of apps and a lot of technology, so that we can go ahead to have a much better environment. The third thing, I think we talk about genomics now. We talk about genetic counseling, so those things are upcoming, and India is practicing in many areas to identify anomalies, congenital anomalies, so we can reduce the problem. As well as I brought some statistics where it talks about the diagnostic error stand in the hospital more or less 7% of the baby who comes to our hospital. 7 is a huge number. Out of 100, 7 of them are having the misdiagnosis. There are many studies. One of the studies, it is setting-wise where it is conducted. Actually, in Indian study very difficult to get and having data. But this is a study done in 2023 in Andhra Pradesh. It talks about 3 to 12% high risk baby comes to emergency are having misdiagnosis. So that's very bad, and it is much more higher when you happen to go for autopsy. So that comes again 20%. So that's very scary data. 2025 there was another study which was conducted in India, and it talks about 2.6% kind of misdiagnosis from measured, that is measured. And out of that, half of them seems to be very fatal and having mortality. So very scary, ma'am, to look at that. So anyway, we need to work on, and thank you so much for bringing up many points here. So coming to, I'm so privileged along with all of you that we have got another very focused, eminent doctor, Dr. Rasna Das, and who is from this soil, and then she has completed her MBBS, and she was a gold medalist, and reflected in her brief CV. She also have completed her MD medicine in pediatric, as I remember, from a very prestigious institute called PGI Chandigarh. She has done one more additional very special course for pediatric from PGI Chandigarh, and she was the founder pediatrician for one of the very esteemed institute which is called NEGIMS in Northeast India. She also have actually contributed while NICU PICU was built in NEGIMS. She has developed protocol policies how to deal with the newborn and lot many things, and she is with us today. So let us hear from her how to look at the diagnostic and medication error for children, ma'am, from medical perspectives.
Thank you very much to all of you for inviting me here. Actually, I feel like the odd person out, but I think I was looking at the presentation before this particular topic, and I was so impressed. All the papers that you have done, even doctors are not doing that kind of research. So that is one of the things which is very important in any patient or healthcare. It's a collaboration between the specialities, whether it's between two specialty doctors, or between the doctor and nurses. And I think that is one of the most important aspects when you talk of not only diagnostic error, but even medication error. So diagnostic error, I think Parul Baido has already told us in detail that so many things can happen in so many different ways. But I agree with her in the fact that we are so overloaded with patients. If you ask a pediatrician who is working in the government sector as to how many patients you have seen in the whole day, say maybe 6 hours, it usually crosses more than 100. So how many minutes are you giving to each patient? We are not. Hardly 1 or 2 minutes. I have heard of situations even in Assam, in nearby CHCs and PHCs, where the pediatrician is having 3-4 patients together in the same room, and then before the mother is able to open the mouth, the doctor is already writing the prescription. So where is the diagnosis? So there is error right from the beginning. So I think we are overburdened with the fact that we are having the doctor-patient ratio is very bad. Though the government is trying to bring it to the WHO guidelines, but we have not succeeded. And as Dr. Parul has said, we are overloaded with pediatric patients. Parents come late, so many a times that is one of the reasons that the diagnosis gets delayed. Sometimes they come to us, and then there is also a tendency in our country that you do a lot of doctor shopping. So what happens if you come to me the first day, you have a day 1 of fever, and I tell you just hang on, wait. No, they will go to another doctor and try to get some medication. But if that doctor also doesn't agree, they'll go to the pharmacist and get over-the-counter medication. So sometimes when these things are done, then the diagnosis of a particular ailment becomes a problem for the treating doctor. See now, before I think if you read even your books, if you say for malaria, for typhoid, it's a very particular pattern of fever which is described. I'm giving you a very simple example. So if you have, say, cerebral malaria, the fever will be different. If you have malaria because of vivax, the fever pattern is different. According to the books, in typhoid fever, you call it step ladder. Slowly, 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 it will rise. But in my practice, in our clinical practice now, we don't see those kind of things. We cannot diagnose because paracetamol is given even at 98 degrees centigrade. Understand? So 98 degrees, sorry, not centigrade, 98 degrees Fahrenheit. Mother will say, this is Iman Jor, but Iman, how much is the fever? 98.4, but that's normal. So one is, as Madam has already pointed out, the lack of knowledge in our society. The other fact, you are talking of AI, but there's another aspect to that parents are using AI and then they're getting into the wrong kind of information. So if they will not believe you, but they will go on believing the YouTube or somebody's video which is very popular. So they will medicate according to that, and then again it involves in delaying or changing the pattern of the illness, and therefore a delayed diagnosis, or sometimes you're not able to diagnose. And many cases like that happen. I'll tell you my example. Now India is a country which is so vast. It is like many countries in one whole country. So I was, as Madam has said, I was doing my post-graduation in Chandigarh, which is in the northern part. And when you have fever, hepatosplenomegaly, the most common diagnosis there is typhoid. And then what happened, I got shifted from there to Shillong at Negrims. So my typhoid brain was still active. And then I saw this girl with fever, hepatosplenomegaly, and my diagnosis was typhoid. So I sent all the investigations related to that particular condition, and the pathologist rang me up because I had sent a CBC with a peripheral smear. So she rang me up and said, Dr. Rachna, you know what, your patient has falciparum parasites in the peripheral blood smear. Now that was a learning lesson for me because I did not think of malaria, where in spite of coming back to a highly malaria endemic area at that time, 2004-05. So this is the kind of thing in our country because there are so many different areas, so many different regions. Even we, with our knowledge also, sometimes we don't, apply that when we change places. So that is one of the examples I'd like to tell you as far as diagnostic errors is concerned. Anything else you want to ask me?
Thank you, ma'am. I'll come back to you if the time permits. Yes, just to tell all of you, very recently I was just reviewing one of the study, and then a very catchy one of the paragraph is that is advice, piece of advice in this study saying that when you meet a doctor, particularly pediatrician, you better go along with the medication, whatever is administered or being administered to the baby, and with the correct level and the original level of either syrup or whatever form medicine is there, and you show the doctor exactly, not saying about that I know that this is the medication I have given to my baby. That is not advisable because many occasions, as ma'am is saying, google.com, AI used, so that become more scary. So it is always advised, and as a nurse, I think in a community, we need to talk about it that whenever you seek help to pediatrician, if there is any medication baby is already receiving, go along the medicine without having any kind of transfer medicine to one box to other or from one bottle to other. That's help. And yes, ma'am, doctor nurses demand in India is definitely, that there is another discussion required. Ratio is nowhere up to the mark, so we are struggling. So thank you once again for putting so much of input, and I hope we will be able to learn out of it. Coming to the most hybrid, and it is very unfamiliar to talk about your profile, ma'am, and who is with us, Lieutenant Colonel Vasundhara Pal, and very, very vibrant lady for knowing the subject, how the newborns are taken care of right from the OT, and then how it is managed newborn during that particular phase. And to tell about that, ma'am come from the Navy background, as I am.
I'm from the Army background.
Army background.
Yeah, I'm presently deputed as at a Navy hospital, which is
Navy hospital. Yeah, you are from Army background, and currently working as a OT matron.
I'm nursing officer in charge OT.
Okay, nursing officer in charge OT, correct, in Asbini hospital, and she is going to tell us about how to look at the safety of newborn baby, and more importantly, how to minimize the risk for newborns right from the operation theatre, ma'am. Thank you.
Thank you, ma'am, for the introduction, and thank you for the very rightly asked question. So the newborns, when you talk of the protocol in the operation theatre, there are numerous number of aspects that we have to look for. It starts from the physical setup of the operation theatre, that is the structure of it, the walls of it, the kind of windows it has, the air exchanges unit that it is supposed to have. So the temperature, let's say temperature regulation has to be from 18 to 25 degrees. Then coming to the humidity, it is 40 to 60%. Then it should have high efficiency particulate airway exchanges. The walls should be creaseless, the floor should be creaseless, and also skid free. So a bit about the physical infrastructure of it. Then coming to the type of atmosphere that we have to give, it is supposed to be a near, or you can divide it into ultra clean zones depending on the type of surgery that the newborn or the child is undergoing. So these temperatures may not be very favorable for the newborns or the children. So accordingly we have to have the support system, that is, we should have the warmers, adequate warmers at the right place should be there. Then coming to the infection control, before infection control, I would like to say all the equipments should be functional. There is no probability which is expected to be there for the non-functional equipments. So it is a very high responsibility for every individual who is working, should be trained, repeatedly trained, and the checks and the examinations of the training in the operation theatre is zero error, which is supposed to be there. So the training is supposed to be is supposed to be of a very high standard. Then morning we all come, we check the equipment. If it is not functional, it's our responsibility. We give it up and get it replaced. So that is, in cases of children, is non-forgivable. It has to be functional. Then coming to the sterility, as you all know, OT is known to be and it is supposed to be sterile zone, wherein there are three aspects which we all should follow is hand hygiene, not forgivable if not done. Coming to the hospital-acquired infection-related initiation which may take place in the OT is nearly not acceptable, especially in cases of cardiac and ortho. Cardiac and ortho, if it gets infected, these patients get infected, it is very difficult to get them back to normal. And more so if it is there for the children and newborns. Then coming to the, this is about the skin. Then you have your tradition of safety concerns and the customs that we have. So, in these, the culture that we follow is you all are supposed to be communicating everything. Like we are giving drug, there is a high probability of getting the medication errors. There are so many medications, and like in the ward, there are a number of medications which are there, which are all, so, almost all these medications are high alert. Like in the ward, we have a few drugs which are high alert drugs, but in the OT, it is a huge number, which is maximum is of the high alert proportion. So every single drug which is prepared, especially for the children, has to be rechecked and rechecked twice or thrice by the anesthesiologist and the ORT who is there, or the nurse who is there. So the dose which is prepared or diluted for children is rechecked, and before infusion, the probability it is a zero error which is accepted when it is related to the muscle relaxants, say it induction agents, say it sedatives. So these all things are there which can happen and can lead to a very disastrous result. So these are the factors which we need to take care, and also the newborns when they are born, we have set up wherein every unit is when the mother comes, we check the features of the patient, and in between when the spinal is given or the mother is undergoing cesarean, soon after that there is the present scenario is we give a delayed cord clamping. So that is supposed to be followed in most of the hospitals, and until unless they are doing some research, otherwise the delayed cord clamping is recommended. So then when the baby is born, the temperature, as I told you, it is not maintained at a temperature which is very newborn friendly. So again, the warmer has to be prepared before the patient is undergoing cesarean, and when the baby is extracted, complete, as Ma'am Parul also mentioned, we tend to do a quick examination. That should not happen. Quick examination, when the baby is born, we have missed, as both of our senior faculty has told, with their experiences, they must have found a large number of diagnoses which are missed out. So this should not happen. As youngsters, you should take home. The quick assessment thing is to be not at your level. Whenever you are taking, you should be taking a thorough examination when the baby is born. Even I have experienced the TEF is very commonly, the congenital anomalies are very commonly not diagnosed. So these are the few things which we tend to miss out if we are not very careful. So these are a few aspects which we have in the protocols. Hand hygiene and biomedical waste. Hand hygiene is the first and the foremost step which can take us to a healthier zone or to a fatal zone. So healthcare, every single healthcare member who is working in the OT or in any other department has to be very clear that it is the final step. This is the most efficient step which can prevent infections. And this is the only step which can lead to a full-blown sepsis. So that you must take home this message, and everybody in the OT, we do follow. And how we ensure it is, how do we get to know that we are doing it? For that, the audit and surveillance is very important. There has to be always a regular practice of auditing and surveillance, so that whenever there is a loophole that we find, can be again redone. Plan, act, do it and reassess. Keep assessing it. And you should come to a conclusion that every single member is following it. And this is all I would like to say.
Okay, thank you, ma'am. I have done a lot of work on how to prevent the error. In there is two aspects. One, in the dosing, either it is overdose or underdose, or next is the wrong medicine itself. So these are the areas which we need to work on. And actually, I'm getting alert. We are out of the time, but thank you so much. All of you have put excellent points for learning. and this will surely help all the participants to learn in brief how to take care of diagnostic error and the medication error. Medication error we do talk very commonly, but for pediatric it is little different. But I really want to tell one more thing, that whenever doctor prescribes something which you don't understand or you have any doubt, please come back. Do not hesitate to ask, especially when people write decimal. Suppose 2.0, that's very, very bad prescription, rather it should be 0.2. It's an example. So I request all the participants to be very careful when you work in pediatric setting and dealing with diagnosis and diagnostic procedure, as well as when you deal with, more importantly for nurses, is the medication administration. Thank you once again.
And thank you. Just few slides I am having, I can just within few, I like to just highlight some important points. So just a few slides, just a little one. So there are so many medication techniques are there, so non-invasive and again invasive. So medication, next slide. So there is medication safety. For medication safety, so first we have to involve the all necessary precautions to ensure, already we have told, most important threats are the medication error and adverse medication drug reaction or drug event, misinformation, poor storage and destruction during medications. So we have to overcome that all. And medication error actually includes the prescribing error, dispensing error, transcribing error, administering error and monitoring error. So we have to overcome all these. Next slide. So medication error are most common for the hospitalized patient. It can happen in the home also, and it is the most vulnerable population are the neonates. 84.2% medical error happens in the NICU, and majority of the errors is the medication writing error. So we have to be conscious, everybody has to double check, we have to do, already it is highlighted. And serious error is the prescribing decision error, what drugs to be prescribed. And that's why it is found that 3 times more commonly medication error is found for the pediatric population, mainly in the NICU and SNCU and PICU. Next slide. So it is our shared responsibility between the parents, caregiver and the patients, older patient and the healthcare professionals. So clear communication, accurate information and error prevention should be followed. Safe storage should be done in a child-proof, dry, cool places and out of reach and out of sight of the children. Safe use of medication by the prescription by the doctors or over the counter should be administered according to the body weight, not always of the age. Already madam has highlighted, so according to the body weight. We have to remember that too little medicine can be ineffective and too much can be harmful. So we have to avoid unnecessary medication use also. We have to check the expiry date every time before and after before use. Next, we have to follow the rights of the medication. Next slide. Rights of the medication administration. Previously it was 6 rights, then it came 10 rights, now it is 16 rights. So we have to follow that. Double check we have to always do for the dose calculation and child's identification. Sometimes one child can be misidentified, so identification is very important. Look-alike and sound-alike drugs should be very cautiously used, and checklist or standard operating protocol should be used for the medication administration. These all are the nursing responsibility. Injection safety should be consciously practiced, especially for the IV injection. If it is administered by the for the antibiotic, that should be used to administer using the syringe pump, and usually for the newborns it should be administered by 30 minutes. So this type of instruction we have to follow, and the skin preparation, scrub the half of 15 seconds, that also we have to follow for the quality improvement of and prevention of antibiotic resistance and drug resistance. So irrational use of antibiotics should be prevented, safe discard of unused drugs should be and medications should be practiced. And integration of clinical pharmacists is very important. Western country it is practiced but not in our country. Next slide. Regular reporting of adverse drug event and medication errors should be done honestly. We should not hide that medication error. And blood testing should be done if any drugs are used for long term. That is very important to prevent the adverse drug reaction. Specific data is not available, especially in our country, about the adverse drug reaction problems. Another important is pre-marketing that is done but not effectively done, that is pre-marketing assessment of medication safety that we have to ensure by the manufacturer and from the drug regulatory agency. Post-marketing monitoring of the medication safety also should be done. An instruction for the use of medication by the caregiver at home for the long-term medication should be clearly written in the preferred language. And awareness generation, not using the use of drugs from the Google and the over-the-counter medicine should not be done for the pediatric population to prevent the adverse reaction. And we have to also make them aware about the unnoticed interaction about the traditional medicine and homemade remedies. Majority of the population we have found in the rural area, they are using the homeopathy and allopathy or traditional medicine together. So there can be unnoticed interactions of the drugs, and that can lead to so many medication error and harms for the pediatric population. So for the medication safety, use it right. Close the container of the medication tightly out of the sight of the children. Thank you very much.
We could not give so much of time, but Maitri Sarkar A, RN Tagore Hospital, Kolkata, West Bengal. For the research paper competition, first prize goes to Saraswati C, Kaveri Hospital, Chennai, Tamil Nadu. And for the poster competitions, the first prize goes to Raima Lucas, College of Nursing, Command Hospital, Eastern Command, Kolkata, West Bengal. Second prize goes to Major Tushara T, College of Nursing, Command Hospital, Eastern Command, Kolkata, West Bengal. Third prize goes to Miss Vindumol Matthew, Bhakti Vedanta Hospital and Research Institute, Thane, Maharashtra. I request Raima Lucas, first prize poster competition, Major Tushara T, second prize poster competition, Ms. Vindumal Matthew, third prize poster competition to kindly come up on stage. Third prize, Ms. Vindumal Matthew for poster competition. Congratulations to all of you. The rest of the participants of poster competition, you can collect your certificates from the backstage, and the posters of all the participants, you can collect it from the lobby. Now, I request Madam Dr. Mansi Sengupta to kindly come up and hand over the live book of ANEI to our committee members. I request Madam Mary, Madam Lavita, Madam Sujana, Madam Sangeeta, Madam Superior, Madam Rivanka. I request Madam Lavita to come up, Madam Sangeeta, Madam Superior, Madam Anurupa, Madam Nabanika,
Madam Susanna. Madam Rivanka. Madam Smriti. Madam Vijaya. Madam Anita. Madam Pinky. Madam Vanita.
Hello?
Madam Reshma. Madam Papuri. Madam Geeta. Madam Rumu. Madam Navajani. Madam Mary Kuti. Madam Imba. Madam Aparajita. I request Madam Munmana to hand over the book to Madam Mansi. Madam Ranju.
Anchor for the day.
Patient Safety Conference at AIIMS Guwahati, a grand success. We are deeply grateful to our chief guest, Professor Dr. Ashok Puranik, a guest of honor, Dr. Michael Ramsey, and all the distinguished dignitaries for the inspiring presence and guidance. My sincere thanks also goes to the Director of AIIMS Guwahati and the esteemed faculty members for their constant support and encouragement. I thank our founding member, Madam Thankam Gomez, Madam Ajita, and Dr. Omona Purbahai for being a constant support, Madam Manashi, the President of ANEI Northeast Chapter, and all the organizing team. A special thanks also goes to our speaker and panelists for sharing the valuable insights, to the ANEI Patient Safety Fellows for the innovative presentations, and to the 519 delegates from across India for the active participation. Thank you one and all.
Thank you everyone for patience listening and sitting for entire day over here. I'm just standing here just to announce the news what you already know about, that Assam heartthrob, the singer, actor, social activist, no more at the age of 52 years at Singapore. So I humbly request you all to stand up for 1 minute for silent prayer.